So, again if we look into the history of the disease, we will find that before this disease was identified, what was the etiological agent, there was a particular disease that was predominantly prevalent even in the ancient times, but the uprising actually came with the industrial revolution, where people were getting affected and slowly they become malnourished and often people died. This disease was pretty much undiagnosed for a much larger part of the history, and in some regions this disease was even glorified. At that point of time, this disease was called as the disease of consumption. That means something is consuming the person from within. Similarly, in an Indian context, the similar disease was also described, and it was also called as Kshay Rog, or in Bengali it is called as Khoy Rog, means the same thing. During that time, Robert Koch, he was studying the people who had died of this disease called consumption, and when he was studying the lung samples of the patients who have died of the disease, he found out the etiological agent. He was trying to stain the histological preparations, and during that staining he used acid, and after staining he saw that there was some bacteria, they were not decolorized even after using the acid, and hence he called it as acid fast bacilli. Why bacilli? Because it was a rod shaped structure. That was the first identification of this bacteria. Later on, this bacteria was cultured on and studied, and people found out that this bacteria on its cell wall has a different composition. It is composed of mycolic acids. Hence, it was named as Mycobacterium. And because it was causing the disease as tuberculosis, the organism was called as Mycobacterium tuberculosis. That was how this organism was identified. Further on, after this organism was identified and cultured on, various antimicrobial agents which were then discovered were used to treat. Initially, before the advent of the antibiotics, the predominant treatment was increasing the immune status of the patient so that the patient might recover. Till today, tuberculosis is still prevalent. It is still one of the biggest disease today. Even with the increased nourishment of most of the people, increased hygienic conditions in which the people live, yet tuberculosis is very much prevalent. There are two important aspects that we have to understand. The first important is the natural progression of the disease, and the second important part, with today's medical advancements, large number of populations we have who are immune compromised, be people who are living with HIV, be people who are living with malignancies or other immune suppressive disorders. And tuberculosis is a very common disease in this category of patients. Now, if we look at how this disease spreads, the predominant way the disease spreads is through the respiratory route, and the most common type of infection that it causes is pulmonary. Hence, it is called as pulmonary tuberculosis. Nevertheless, the disease can occur anywhere in the body. So, any involvement of the body other than the pulmonary region is called as extrapulmonary tuberculosis. Now, how does a person gets infected? The person gets infected from other people when that infected person coughs or sneezes. The droplet infection leads to the infection of a new person. If we go and read the progression of the disease, tuberculosis is a big topic in itself, but let me make you understand how the disease progresses in a very short form. After the initial infection, the bacteria enters into the pulmonary bed. Over here, this bacteria is an intracellular bacteria. It is taken up by the macrophages, alveolar macrophages, but the macrophages fails to kill the bacteria. What happens then? The same macrophage will recruit other macrophages and try to contain the infection. If the immune status of the person is or the immune response is sufficient, these cells will able to restrict the organism within there itself. If the body fails to do so, the disease will spread throughout the body. When it is restricted, the bacteria may be left in that region, pulmonary region, or into the pulmonary lymph nodes. And over the period of time, I think you have already done in pathology, the calcification can occur. So, this patient becomes infected, but is not diseased. There is an exposure to the organism, but the patient is not diseased. Subsequently, when the person gets reinfected or the immune status of the patient decreases, this infection can flare up. This type of infection is called as post-primary tuberculosis. And if recall, if the person infected at the first time and is unable to contain the reaction, it will call it as primary tuberculosis. Commonly, it will cause inflammation in the lungs. The patient will come with symptoms of cough, difficulty in breathing, and when there is gradual degradation of the pulmonary architecture, the patient may also complain of hemoptysis when the blood vessels get eroded. However, although this is the most common clinical picture, it is not a restricted medical picture. That means there may be other presentations also. So, in today's class, we will discuss more importantly about how can we diagnose this case. Okay. Now, let us look at this picture. So, this is what happens. When the person gets infected, predominantly to the inhalation route, the organism reaches the pulmonary bed where it starts proliferating. Now, the macrophages will try to contain this reaction, and it is a constant battle between the bacteria and the human body. The human body will try to contain it, forming what is known as granuloma. Now, what will be the fate of the granuloma will depend on the immune status. If the immune status is strong, the granuloma will get consolidated, and in the long term it might get calcified. However, if the immune status fails, it may lead to what is known as caseous necrosis. Thereafter, the patient, it might reactivate from the same granuloma, it may reactivate. If reactivation occurs, the bacteria will spread from the pulmonary bed all throughout the body. This is called as disseminated tuberculosis. It may result in tuberculous meningitis, tuberculoma in the cerebral hemisphere, anywhere in the body. The other way around is when this granuloma is contained, many cytokines will act on them, will try to kill the organism. Now, later on it was found out this Mycobacterium tuberculosis is not a single organism. There are many similar organisms which share almost similar characteristics and will cause almost similar disease. Hence, it was called as Mycobacterium tuberculosis complex or MTC, which contains human tuberculosis, bovine tuberculosis, that is Mycobacterium bovis, Africanum, Microti. These all form what we call as Mycobacterium tuberculosis complex. So, when we diagnose a patient with Mycobacterium tuberculosis, we actually mean it is a tuberculosis complex. Furthermore, it was found out that there is another type of mycobacterial infection which causes predominantly skin lesions and destruction of cutaneous structures including fingers, nose, etc. This disease was initially called as Hansen's disease, later on called as leprosy, and the organism was termed as Mycobacterium leprae. It has some differences with Mycobacterium tuberculosis, but it is similar to other mycobacteria, hence it is also classified in the group of mycobacteria. Other than that, there is another important is called as atypical mycobacteria. Now, why atypical mycobacteria? Although they share some of the features of mycobacteria, but they have some differences. Now, also please keep in mind, when we talk about tuberculosis, it means the disease. Similar disease can also be caused by another group of mycobacteria called as NTM, that is non-tuberculous mycobacteria. That means the disease is almost similar, but the causative agent is not Mycobacterium tuberculosis. Those are called as NTM or non-tuberculous mycobacteria. So, broadly speaking, all the mycobacteria can be classified very simply. The first is the Mycobacterium tuberculosis complex. The second one would be the atypical mycobacteria including NTMs, that is non-tuberculous mycobacteria, and finally Mycobacterium leprae. Now, let us consider the diagnosis of tuberculosis, how we can diagnose the case. First, we have to understand the clinical signs and symptoms. Based on the progression of the disease, the symptom patient may be asymptomatic, mildly symptomatic, or severely symptomatic, or grossly cachexic. Next, the modalities of the treatment would be either imaging studies, molecular culture methods, or immunodiagnosis. These are the main modalities. So, what would be the main modalities? Clinical and radiological examination, microscopic and culture methods, molecular methods, and immunological methods. These are the predominant modalities by which we can diagnose tuberculosis. Now, in microbiology, we have these many types of tests. Let us start. First is microscopy. The simplest test that we can do is we can look for the bacteria in the sample. If we are considering pulmonary tuberculosis, the best sample would be a sputum sample. So, in the sputum sample, if we do look for the microorganism, by microscopy we can make a diagnosis. Next, we can use the same organism for culture. We can test for antibody or antigen responses. Then we can do molecular methods like PCR and or sequencing, and another methodology, this is the cBNAAT, that is cartridge based nucleic acid amplification test. This is a type of PCR test, but it is cartridge based, that means human error is limited, hence the diagnosis is much more rapid. Now, as far as microscopy is concerned, even today we are using the same method that was described by Zeal and Nielsen based on Robert Koch's experiments. This is called as acid fast staining. Other method would be using a fluorescent stain. This is called as fluorescent microscopy. The advantage of fluorescent microscopy is that the detection rates are much higher. Nevertheless, Zn staining or the acid fast staining method is still very much prevalent and also incorporated in the national program which the government of India runs, so that tuberculosis as a disease burden in this country can be reduced. So, when we do examine these sputum specimens, if we do find the organism present in the sputum, we need to grade them. Now, why do we need to grade them? The answer is very simple. The first important part is we need to diagnose the case, and second part is we need to treat the patient. Now, when we are treating the patient, we need to monitor whether the patient is actually getting better or not. The simplest method is, if we do give the patient antimicrobial agents, the bacterial load will reduce. If the bacterial load reduces, what will happen? The number of bacteria in the sputum will come down. That is why we need to quantify. This quantification is called as grading. Now, what kind of grading we need to follow? Well, there are many bodies, they have their own specific set of gradings, be it WHO or other bodies, but in India, we will follow the grading that is given in the national program. Okay. The national program is called National Tuberculosis Elimination Program. Other methodology in microscopy would be, if we go and take the tissue out of the patient and look at it with histopathological examination. The most easiest phenomenon that we can find on histopathological examination is formation of granuloma with giant cells. After microscopy, we have another method, that is diagnosis with culture. Now, culture of Mycobacterium tuberculosis is slightly problematic. Why? Because the organism divides slowly. If an organism divides slowly, what will happen? It will take a lot of time for the culture to come positive. We have many methods of culture. We can use a solid agar, we can use a liquid. Obviously, the solid agar culture will take a lot of time. It generally takes 8 weeks for a negative report to be done, whereas in the liquid culture media, we can get as early as within 1 week. Again, the culture methods can be manual or automated, the liquid culture methods. Automated method, using automated methods, what will happen? The turnaround time will get reduced. So, that is the reason why it is preferred. Again, with the culture, what we can do is, we can test the antimicrobial agents used for treatment, so that we can predict whether the particular microbial agent will be effective or not. That is, the susceptibility to antimicrobial susceptibility testing can be done. So, this is the picture of the growth of Mycobacterium tuberculosis on a solid agar called LJ media or Lowenstein-Jansen media. So, this is a typical description of the colony. It is commonly called as the rough, buff, tough. Why rough, buff, tough? If we look at it, it is not a smooth looking colony, that is why it is rough. Buff means the color, it is pale in color but not white. It is called buff in color. And why tough? Because when we do try to pick up the colony with the help of a loop, it doesn't comes out easily. That is why it is called as tough. Similar to the now solid media, I think you know the Lowenstein-Jansen media. Other than that, there are many types of media like Petragnani Dorset media agar, and the other that culture media I told you about is a liquid culture media. Now, this liquid culture media, there are many types of liquid culture media like Middlebrook 7H9, that is most commonly preferred. And this is the machine, this is a automated machine which can detect tuberculosis with the help of liquid culture method. The automated machines will have this kind of tubes which have the media in itself. We need to inoculate the sputum sample and then it will detect. From the culture media, say for example, a tube shows positive result of a growth. Now, this may contain Mycobacterium tuberculosis or other mycobacteria. Easy way of finding it is testing for the tubercular antigen present in the culture or not. This is not tested on human body. Okay. It is a simple immunochromatographic test that detects the tubercular antigen in the liquid culture media itself. Okay. So, this is a much easier method of identification. Otherwise, what we will have to do? We have to look for other metabolic tests like niacin test, this test, that test. It will take further more time, whereas the antigen test will reduce the time. There are many kind of tests like this biochemical test, like nitrate reduction test, amidase test. These ultimately will take a lot of time. Okay. Now comes the advent of the molecular methods. With the use of the molecular methods, the first method that I will discuss is called as the CBNAT or cartridge based nucleic acid amplification test. Now, the national program or the NTEP recommends two types of CBNAT. The first type is the gene expert machine from a company called Cepheid, and the second one is called as a TrueNAT from a company called Molbio. Now, why these are recommended? Because these are closed systems. Closed systems means when I am trying to use it, I do not need to manipulate anything. The only thing I need to do is I need to take the cartridge, inoculate the cartridge with the patient's sputum sample, and then put the cartridge back into the machine. The machine will run the PCR and will give the result. Two are recommended. Other than that, we can there are many modules which can do PCR independently. Now, I have already told you, other than Mycobacterium tuberculosis, there is atypical mycobacteria. Now, atypical mycobacteria, there are many atypical mycobacteria. Now, these mycobacteria have different susceptibility pattern based on the species. We also need to identify them. There is another method, it is called as the line probe assay. Now, what this line probe assay does that? From the growth of the either solid or liquid media, we use hybridization and look for the species. Okay. Wherever the band is forming, it will tell us whether it is a MTBC means Mycobacterium tuberculosis complex or NTM like Mycobacterium kansasii, Gordoni, etc. So, this is another method by which we can identify the organism. Now, let us look at this chart. This chart is from our national program. Now, what does this chart say? When you are trying to diagnose a case of tuberculosis, first is presumptive tuberculosis. Presumptive tuberculosis means a person who has some clinical manifestations which may resemble tuberculosis. So, what we need to do is we need to ask the patient to go for a smear examination. Now, in this case scenario, we are talking about pulmonary tuberculosis. So, the best possible sample will be a sputum sample, and we need to get a chest X-ray done, so that we can look at whether there is any pathology radiologically can be seen or not. On smear examination, if it comes positive and the chest X-ray is suggestive, we can call it as microbiologically confirmed tuberculosis, right. Now, if it comes negative, then we need to go for CBNAT, that is the molecular diagnosis. If the CBNAT comes positive, then also it is called as microbiologically confirmed tuberculosis. Okay. Now, if say both smear and CBNAT comes negative, but the chest X-ray is suggestive of tuberculosis, then we will call it as clinically diagnosed tuberculosis. Now, when we are saying clinically diagnosed tuberculosis, that means it either microbiologically negative or not confirmed, but we can never say it is microbiologically negative, because every test has its own limitations. Okay. So, this is the broad way by which we can diagnose. Okay. In today's class, we will not discuss about the extrapulmonary tuberculosis or the HIV infected tuberculosis, because obviously it will get overloaded for you. Okay. So, the main crux of diagnosis in case of tuberculosis is we have to identify the patient based on the clinical signs symptoms, then we need to do microbiological investigation, so that we can confirm it as a case of microbiologically confirmed tuberculosis. Additionally, we also have to do radiological investigation like chest X-ray, it could be a CT scan, etc. Okay. Pediatric pulmonary tuberculosis is a little bit different. I am not going to discuss. Similarly, extrapulmonary tuberculosis, I will talk about it in the next class. Okay. Now, till now you have understood what is the infective form. Now, there is another important form, it is called as the persistent latent infection. Now, what is that? Look over here. Suppose there is a person who is actively infected with tuberculosis. Many people come in contact with this person. What will happen to them? From the source patient, all the people who are getting exposed, among them 30% will have infection and 70% will have no infection. If the people is getting not infected, they will not have the disease. Now, we have to understand what will happen to the 30% of the people who are getting infected. Among the 30%, you see about 90 to 95% will be able to resist the disease. They are infected, but their body will resist the disease. These patients are called as persistent latent infection. Now, why they are important? Whenever, look over here, the immune status of the patient is high, but this the same patient, when their immune status decreases, there is reactivation of the disease. Have you understood? Very small percent of the people will ultimately develop primary disease. Okay. These are the two, there is the microbacterial virulence and this is the host immunity. Now, let us take an example, a person who is, suppose India is endemic for tuberculosis. When I say endemic, that means every person is infected at some point of time in their life after birth. Not every, please try to differentiate between disease and getting infected. Okay. Suppose a person from, say, New Zealand, where there are no tuberculosis cases, he or she comes to India. What will happen? He or she will get infected. May or may not have the disease, he will get infected. So, there is 30% of the chance, if he or she comes in contact with a patient with active tuberculosis, there is 30% chance that that person will get infected. Within that 30% chance, 90 to 95% chance is, if the immune status of the patient is high, will be able to resist the infection, and there is a small percentage that the patient will develop primary tuberculosis. Okay. Now, there is a screening process. I am just giving a small idea about the screening process. We will discuss it later on. What is this screening process? I have already told you, sometimes the patient may be infected or in the early stage of the disease, but will have no signs and symptoms. So, what happens? If the patient have no signs and symptoms, they will not come to the doctor, they will not get screened. Hence, that is a potential source of spreading the infection. So, we need to identify them. How can we identify? Look at this chart. Look for signs and symptoms of tuberculosis. If there is no signs and symptoms, if it is present, we need to follow the previous chart. Get a microbiological test done, get a radiological test done. If there are no signs and symptoms, what we can do? We can do a test called as IGRA or a chest X-ray. Okay. If both are negative, we have to look for history, examination of lymph nodes for extrapulmonary tuberculosis. I will talk all about this later on when we will talk about extrapulmonary tuberculosis. But what is more important, we need to check the history of the patient, whether this patient has any previous history of tuberculosis or coming in contact with the patient with active tuberculosis. Those history becomes very important. Investigation wise, we can do the first test, what is called as the IGRA test, and in the countries where tuberculosis is not endemic, we can do a Mantoux test. That we will study later on. Okay. So, this is a little bit about Mantoux test, in which the tuberculin is injected, and if the person is already exposed to the bacteria, that person will mount an immune reaction. Okay. Thereby we can say whether he or she is infected or not. But keep in mind what I am talking about, if the person was previously infected, may or may not be diseased. So, in the Indian context, the Mantoux test has very limited application, because invariably most of the patients are already infected. Even giving the BCG vaccine is also infecting a child. Okay. Now, these are the few chest radiographs to show you. Now, look at this. This is a very typical description in which you can see a round shaped opacification over there in the right upper lobe. Another presentation commonly seen in case of primary tuberculosis, in which it spreads rapidly. You can see there are small opacification throughout the lung field. This is called as miliary tuberculosis. Another type is called as the fibrocavitary. Now, what happens in the fibrocavitary? When the organism is spreading rapidly within the lung bed, yet the body starts fighting, it will try to contain. But the destruction of the local area occurs, forming a cavity. Now, when the cavity formation occurs, the patient will cough and expectorate vigorous amount of expectoration. These patients are highly infective, because within the cavity is the tuberculous bacteria is very high in number. Every time this patient coughs will throw out a lot of bacteria. These patients will ultimately also result in hemoptysis. Why? Because when the pulmonary bed is getting eroded, a vessel may get eroded, and then the blood will come into the cavity and the patient will cough out the blood. A typical description of tuberculosis that you may have read in the literature or in movies. Now, this is the primary complex. What is this primary complex? When the person gets infected, not the disease is infected, what will happen? The disease will be limited in the small areas in the pulmonary bed and in the mediastinal lymph node. This is called as the primary complex. So, these are the common manifestations. Other than this, there are various types of presentations which can be there. Like, I think you can see this, there is a clear cavity in the right upper lobe with consolidation surrounding the cavity. That means inflammatory process is going on around the cavity. And on the left hand side, I think you can see there is a big cavitary lesion on the left upper lobe. So, these are the X-rays which are suggestive of tuberculosis. Okay. Similarly, we can also go for a CT scan of the chest. Okay. So, this is all about, in a very nutshell, the diagnosis of tuberculosis. Now, coming to the other important part of the topic that we have to do today is recall. Initially, I started how the organism was identified when Robert Koch was found out that these bacteria were resistant to decoloration by acid. This led to the development of acid fast staining. Now, what is fast? What do you mean by fast? Fast means to resist the activity. Okay. The early morning we take the breakfast. What is breakfast? We are breaking the fasting. Fasting means resisting the intake of food. So, in this case, the fasting would be resisting the action of the acid. So, what is commonly done is that in the sputum microscopy, we need to test for Mycobacterium tuberculosis. We can do this by the method called as Ziehl-Neelsen method. Under this method, what we have to do is we have to prepare the slide, then we have to use what is known as a carbonyl friction. Carbonyl contains phenol. Now, why phenol is used? Recall, I have already told you, mycobacteria has mycolic acid on the cell wall. This results in the resistance. So, if we need to stain this bacteria, we need something so that the stain can enter into the cell. Otherwise, the stain will not enter and the whole process will become a failure. Phenol is added so that the stain can actually penetrate in the cell. And why carbonyl friction? Because the stain is friction. Have you understood? Furthermore, the mycolic acid has waxy consistency. This is the reason why we need to heat the stain. At a higher temperature and in presence of phenol, penetration of friction in the cells increases. Okay. Next, what we need to do? We need to use acid. Now, what will be the concentration of the acid? That is determined by the species of mycobacteria. For your purposes, you need to learn two concentration. The first concentration is 5% sulfuric acid. This is used to stain Mycobacteria leprae, and the other is 25% H2SO4 that is used to stain Mycobacterium tuberculosis. Now, please keep in mind, if you use 5% acid, Mycobacteria will still be acid fast. But if you use 25% acid, Mycobacterium tuberculosis will be acid fast, but Mycobacterium leprae will not be. Okay. What I am trying to imply is the strength of the acid means the strength to which the Mycobacteria can resist decoloration. Okay. After that, we give a counter stain so that the background may take up the counter stain. Importance of using a background stain is that we can identify the bacteria easily. Now, because the friction is red in color, the bacteria will take up the stain and retain them. It will be red in color. Red color things are much more easily appreciated if the background color is blue or green. Hence, the counter stain will be either methylene blue or malachite green. This is the overall process. Now, let us look at the how this process is done. Called as Ziehl-Neelsen. Please keep in mind the spelling of Ziehl and Neelsen in your practical copies. Don't get it wrong, and please don't write just Zn staining. Whenever you are writing, please write the whole name. Next is, it was first introduced by Paul Ulrich, I have already told you. Then modified by Franz Ziehl and Friedrich Nielsen, hence it was named as Ziehl-Neelsen staining. There are many modifications of Zn staining. Today you first learn the main method, then we can discuss about the okay. So, this is the difference between a gram positive bacteria, a gram negative bacteria and a mycobacteria. You can see there is a presence of mycolic acid layer at the outermost part of the cell wall. Now, the acid fast bacilli or the mycobacteria, when we do stain with gram stain, will appear as gram positive bacteria. Okay. Now, what are the materials that we require? The first would be, we need a slide, we need a lamp, we need the sample, we need a loop or a swab stick to make the smear, microscope. Now, the stain, we need carbonyl friction, acid alcohol and methylene blue. The reagent will be carbonyl friction, decolorizes 25% H2SO4 and methylene blue. Now, what was the process? Take a clean grease free slide. Now, when we say grease free slide in your examination, many of the students were saying that we need to heat to make it clean. I don't know, that's wrong. The purpose of heating the slide slightly is because there is a layer of grease in the slide when it comes in packets, so that the slides don't stick with each other. Now, if you don't make the grease, you don't heat the slide, what will happen? The grease will be present. When you make the smear, air dry it, and then you wash, the smear will be washed off. Okay. So, this is how we make it grease free. There are many methods of making it grease free using alcohols, acid, etc. Easiest method is passing it over the flame. It is not heating the slide, it is passing it over the flame. Okay. Then we prepare the smear, air dry it and heat it. Please keep in mind always, when we are making a smear with the sputum sample, that sample is potentially infectious. Do not heat the slide before the slide is dried up. Otherwise, you will get infected. How? If you heat a wet slide, what will happen? The water will evaporate and some bacteria might, with the action of, with the water vapor, also come in the air and you will inhale. So, never heat before it dries. Okay. Then we flood the slide with carbon fusion and heat the slide underneath with the help of a lamp or a flame. How much we will heat it? So that we can see vapors arise from the top of the carbon fusion. If you heat it too much, it will be very dangerous. Why? Phenol is a type of alcohol. It is very dangerous. So, we will heat till that extent when we can see some vapors comes out from the carbon fusion, and let it stay there for about 10 to 15 minutes. After that, we decolorize with acid alcohol. How long we will decolorize? We will take the slide, we will pour drop by drop the acid alcohol till the yellowish color comes. Whenever we are putting alcohol, the carbon fusion color will change to yellowish color. As long the yellowish color comes out, you have to decolorize. When the change of color, that is from yellow to colorless, occurs, you stop decoloration, rinse with water and then put methylene blue or malachite green, whatever that is provided. Keep it for about 30 seconds to 1 minute, rinse the excess, dry the slide and observe it under oil immersion microscope. So, this is the process: carbon fusion, then decoloration, stop the decoloration with water, counter stain with methylene blue or malachite green, wash, air dry it and then
Carbon fusion will keep for 10 to 15 minutes. Carbon fusion
5 to 10 minutes is enough. পুরোটাই ডিপেন্ড করছে তোমার স্মিয়ার কত তুমি থিক করছো, কতটা ইয়ে করছো. If the smear is well prepared, it will take lesser time. Go and read it. Now read. You have to perform today. Look at point number 4. It says steam the smear. That means we need to heat so that steam comes out. It should not boil. If it boils, then it is very dangerous. It will be very harmful. Okay. Then flood with acid alcohol, decolorize, methylene, air dry, and then look for microscopic observation. This is how it will appear. I have got a better microscopic image. So, this is how it appears. This is how it appears. Now, look in the background. This is a very good example of a sputum positive for acid fast bacilli. Look at it. We have pus cells over here. And the pus cells, that means there is inflammatory process going on. Along with that, we have some mucin strands. Why these mucin strands are important? Because when this inflammatory process goes on, the body tries to encase it. So, we need structures, those are the mucin strands. Now, these mucin strands are present, the pus cells are present, it represents an inflammatory process, and along with that we have red colored thin, slender bacilli. If we look slightly closely, you can find that the staining is not uniform. Rather, in some areas like this bacilli, you can see this part is well stained, then irregular staining, again well stained, then irregular staining. It almost looks like a bead, like bead of necklace. Hence, it is called as beaded appearance. Okay, beaded, it's not beaded structure. Appearance is beaded. Okay, this is how a typical Mycobacterium tuberculosis will appear on acid fast staining. Okay, so this was all about today's class. I think you have understood why this is important, and in the context of diagnosis of tuberculosis, the disease itself, what we need to do. Okay, so if we need to recapitulate, what would be the laboratory diagnostic methods of tuberculosis? The first would be, most important is the clinical signs and symptoms along with radiological. Radiological means chest X-ray in case of pulmonary tuberculosis, or chest CT scan, and in case of extrapulmonary tuberculosis it could be anywhere. It could, in case of abdominal tuberculosis it could be a abdominal CT scan. In case of tubercular meningitis it could be a CT scan of the brain, etc. Now coming to the important microbiological diagnostic part, first is the microscopy. Under microscopy we have direct microscopy, in which we can use acid fast staining method like Ziel-Nielsen method or fluorescent staining method. Another methodology would be using the tissue as a sample and getting a histopathological examination done. Next important part would be using culture. Importance of culture is that if we do, or if we are able to grow the organism in the lab, we can test for the antimicrobial susceptibility. Okay. The culture could be on solid agar, it could be on liquid agar, it could be manual, it could be automated. Next part of the diagnosis comes is the molecular methods of diagnosis. Molecular methods of diagnosis is PCR, that is the conventional PCR, and the CBNAT, that is the cartridge based nucleic acid amplification test. Two tests are recommended by the national program. You need to learn that. GeneXpert by Cepheid and TrueNat by Molbio. Why? Because they reduce the turnaround time of diagnosis of tuberculosis. Okay. For identification of the organism, we can use the metabolic methods like production of various enzymes or utilization of many carbohydrates, etc. Or we can use molecular methods like lateral flow or reverse hybridization method for identification of not only Mycobacterium tuberculosis complex but also atypical mycobacteria, including non-tuberculous mycobacteria. Okay. This is how we need to diagnose. Even though we have so many modalities of diagnosis, many a times we will not be able to confirm the presence of the organism microbiologically. Okay. If we are able to do so by any method, be it microscopy, be it culture, be it a molecular method, we call it as microbiologically confirmed tuberculosis. If we are not able to do so, then we call it as clinically diagnosed tuberculosis. Okay. Okay.